Okay. Yeah. Good morning. Good morning.
Sir, Kapoor sir will be joining approximately 9 o'clock, 1 or 2 minutes.
Yeah,
So,
sure. I'm waiting.
okay, sir. Thank you, sir.
એટલે બારણું બંધ કરો, અવાજ આવે છે.
टेबल पुसायचं फक्त एवढं सांग.
Good morning, Anand.
Good morning, Rajendra sir.
Good morning, Gaurav.
Good morning, sir.
Good morning, Mahendra sir. Uh,
Good morning, good
Sir,
morning.
Kapoor sir will take around 5 minutes. Sir, ask me to start. Sir, you can start, sir, now, sir.
Good morning, Mahendra.
Good morning.
Desai here.
Sai, how are you?
I'm good.
In Hyderabad or somewhere else?
Hyderabad.
Okay, great. So good morning all. Let us start the program. Since Dr. Kapoor sir is a little late, I invite our speaker Gaurav Bose, who is a resident of FNB Minimal Access Surgery, and he'll be talking about pre-operative evaluation of a patient undergoing bariatric surgery. And pre-operative evaluation is the most important part to take any decision for bariatric surgery, choosing a patient, choosing a procedure, and even outcome. So I think this is the most important topic which he's addressing today, and let us see his views, and we will then have discussion at the end. Over to you, Gaurav.
Thank you, sir. Good morning, everybody. I'm Dr. Gaurav, resident of FNB Minimal Access Surgery, and I'm here to talk about the preoperative evaluation of a patient undergoing a bariatric surgery. So, to begin with an overview, that obesity today is a worldwide chronic condition that affects both the children, the adolescents, the adults, health and economic impact. It's a complex condition which doesn't is not just um, so maybe insufficient. So we need to manage it by multiple modalities. The management necessitates a comprehensive approach by combining multiple modalities for a long-term success. As in it requires a healthy diet, exercise, a behavior modification, psychological support, um, and a foundational therapy for treatment methods. The medical and behavioral approach to weight loss may be ineffective for many individuals with obesity. So there is a role of a bariatric which are really getting common worldwide. Surgical procedures performed to manage the obesity are collectively referred to as the metabolic and the bariatric surgery, which is derived from the Greek word which baros, which means weight, and the iatrikos, which means medicine. So bariatric surgery has proven to be a critical tool for managing the obesity and related comorbidities. Um, for example, the most common is the diabetes mellitus, which is based on the foregut and the hindgut hypothesis. Selection of the treatment modality should prioritize the maximal clinical benefit in terms of weight loss and overall quality of life while upholding the organ function and its integrity. This is a small schematic diagram showing the foregut hindgut hypothesis, in which we know that the ghrelin, which is an orexigenic hormone which increases the appetite of a person, is bypassed in a bypass surgery and decreases its release. And also, while we bypass the proximal bowel, it bypasses the anti-incretin factors, and the food directly reaches towards the distal bowel, wherein the incretins, which is a GLP-1 analog, helps in insulin production and thereby helps in controlling the diabetes. So what data do we have so far? The weight loss outcomes of the various modalities have been listed here. For example, just the dietary and the lifestyle modification helps to reduce 4 to 6% of body weight. The anti-obesity medications helps to reduce around 5 to 20% of total body weight. The endoscopic bariatric therapies have also been helpful, which helps in reducing 13 to 20%, while the bariatric and metabolic surgery that we are to discuss uh, helps in reducing up to 40% or even more of the total body weight. The results of these therapies for weight loss must be reviewed every 3 months, and where there is no benefit or progression in relief, even after 6 months, the escalation to therapy or the next step becomes necessary. So clinically significant weight loss is defined as a weight loss which is more than equal to 5% of the baseline weight for a period of over 6 to 12 months. There are few studies which help support the evidence of the utilities of a bariatric surgery. For example, the Utah and the Swedish study, which had showed that 29% reduction in mortality following a bariatric surgery. The Stampede control trial which compared that bariatric surgery versus the single use of intensive medical therapy for the management of diabetes, in which we had found that bariatric surgery along with intensive medical therapy was more effective as compared to medical therapy alone, which ranges from 24% with bariatric and medical therapy versus only 5% in managing hyperglycemia with just the medical therapy. Shore and his colleagues had also demonstrated the HbA1c control following laparoscopic sleeve gastrectomy and laparoscopic Roux-en-Y gastric bypass. So we must know what modalities do we have in our armament to offer to the patients. To begin with the endoscopic procedures, the intragastric balloons like the Orbera, the Resurface, and the Obalon, which are the single, double, and triple balloons respectively. Then we have the primary obesity surgery endoscopically, the restorative obesity surgery endoscopically, and the transoral gastroplasty. Whereas on the other hand, we have the surgical procedures like the restrictive procedure, namely the gastric banding and the sleeve gastrectomy, the malabsorptive procedures like the biliopancreatic diversion with and without the duodenal switch, and also the combination of both, that is both restorative as well as malabsorptive, that is a Roux-en-Y gastric bypass and the mini gastric bypass, also known as the single anastomosis gastric bypass. So we must know what are the prerequisites and which centers are amenable to perform the surgeries. These are the comprehensive centers which have to be compliant with the metabolic and bariatric surgery accreditation and quality improvement program, the core standards, with successful site visits which must maintain a minimum of 50 approved bariatric stapling procedures annually. There must be a team of experienced surgeons, establishment of a data-driven patient selection, a diligent evaluation as per the prevailing guidelines, and a standardized evidence-based protocols for better outcome and patient safety. So what is the importance of a preoperative evaluation? We know that a preoperative evaluation for a bariatric surgery acts as a cornerstone in the management of the patient. And to begin with, I'd like to highlight that the preoperative care of the patient starts even before the patient arrives at the clinic. What I mean to say is that the patient must be motivated. He or she must have that insight as to what he or she is going to achieve following the surgery. So for that, we need to first optimize the surgical outcomes. That is a proper preoperative evaluation, which can reduce the risk of complications and improve the long-term results. We need to identify the patient's comorbidities, the chronic diseases, the ongoing ailments that the patient need to be optimized for prior to surgery. The psychological readiness of the patient, ensuring that the patient have a realistic understanding of the surgery and are prepared for lifestyle changes required. The multidisciplinary approach, involvement of a team that includes the surgeons, the dietitians, the psychologists, the anesthesiologists, and other specialty, the physicians who must ensure a comprehensive care. Now comes the question that whom should we operate? So the National Institute of Health has laid down its guidelines. That is a BMI of more than 40 kg per meter square. That is a class 3 obesity. And a BMI of more than 35 kg per meter square. That is a class 2 obesity with comorbidities, which may include type 2 diabetes, hypertension, dyslipidemia, obstructive sleep apnea, obesity hyperventilation or the Pickwickian syndrome, the non-alcoholic fatty liver disease or the steatohepatitis, GRD, debilitating arthritis, to name a few. Or the patients who have failed at non-surgical weight loss methods and certain special populations, which I'll deal later on, adolescents under specific criteria, and patients who are seeking for a revision surgery. So this table shows that the WHO classification of weight status, which we are all aware of, that is a weight of less than 18.5 BMI is called as underweight. And regarding the obesity, we have class 1, class 2, and class 3, namely from 30 to 34.9, 35 to 39.9, and 40 or above. Whereas in the Asian and the Southeast Asian population, the BM overweight is considered to be a slightly less than that of the worldwide WHO criteria, in which we have a BMI of 20 above 23 to 24.9 as overweight and obesity for more than 25 kg per meter square. As per the Indian Obesity and Metabolic Surgical Society, The bariatric or metabolic surgery is recommended as a primary treatment modality for patients with a BMI of 35 or more without the presence of any obesity-related comorbidity. In a patient of BMI 30 or more in the presence of two or more obesity-related comorbidities, and for patients even 27.5 or more BMI with uncontrolled type 2 diabetes mellitus despite optimum medical management. Also, the waist circumference, as in case of females, is more than equal to 80 centimeter and a male more than equal to 90 centimeter with a type 2 diabetes and other obesity-related comorbidities. Patients below 18 years of age and above and up to 60 age, these are fall under special categories, but these patients also can undergo bariatric surgery as per the late guidelines, which we'll deal later. All the patients should be motivated to enter a long-term weight management program and should be committed for a lifelong follow-up, which must be provided by the bariatric team. A recent article has been published in the Lancet as early as the January 2025, which has redefined obesity, in which it has said that the new evidence-based definition distinguishes clinical obesity, which is a chronic systemic disease state directly caused by the excessive adiposity, from a state called the preclinical obesity, in which there is no current organ dysfunction or limitations to daily activities, but there are increased future risks. So this article states that given the limitations, just we use BMI as a modality for assessing a patient who has to undergo the bariatric surgery. There are other body measurements like the waist circumference, the waist hip ratio, and the waist to height ratio. These also should be taken into consideration. And for patients who are in the category of preclinical obesity, the risk mitigation will be of prime importance, as in the low risk patients are managed by lifestyle changes, and the increased risk patients may need a medical treatment along with the lifestyle changes, or later on may end up into surgery. Like all patients which are being treated by several modalities, we have contraindications even here for bariatric surgery also. There are few absolute and few relative contraindications. Uncontrolled or untreated eating disorders like the bulimia, or in disorders like the Prader-Willi syndrome, where there is an irresistible desire to eat, falls under the absolute contraindications. And their active or untreated psychiatric disorders or any cognitive mental disorders like depression or psychosis, and ongoing substance abuse or its dependency on these substances may act as contraindications to metabolic and bariatric surgery. Then there are relative contraindications like patients who are at high perioperative risk, like patients with unstable cardiopulmonary status or severe coagulopathy, and patients who have the inability to comply with a further lifelong lifestyle change, nutritional requirements, and supplementation, and patients who are non-compliant to commitment to further follow-ups or with poor family support. Patient education and consent becomes very important in this situation. We have to explain the patient about the surgical risks and benefits. A detailed discussion about the potential risks and the benefits must be informed to the patient. The post-operative care period, we must emphasize the need for a post-operative nutritional management, supplementation. The physical activities must be done by the patient even post-surgery. The patient must have a psychological support and must be ready for a prolonged follow-up. We must take an informed consent from the patient, and proper documentation must be maintained regarding the procedure, the risks, and the future changes in lifestyle which the patient has to undergo through. So coming to the evaluation part, this slide enlists the things we need to evaluate in these patients, starting with the anthropometric measurements and the indices, the dietary habits and patterns, the previous attempts at weight loss. The psychological evaluation must be done along with the evaluation of the eating habits of the patient, the medical history, the assessment for comorbidities in relation to obesity and otherwise, then routine investigations and disease-specific investigations, any relevant imaging, the family history of the obesity associated loss, and abdominal surgery which has been previously undertaken. Coming to the medical evaluation, the proper history must be taken that the patient has ongoing things like a type 2 diabetes mellitus, hypertension, obstructive sleep apnea, or an obesity hypoventilation syndrome, as in the patient is taking any management for the same, or any other medical issues like cardiovascular disease or deep brain thrombosis or any other chronic ailment should be taken into consideration. Certain medications itself, when taken by the patient, may increase the weight of the patient. So those also must be taken into our evaluation history, like antihypertensive medications, antidepressants, antipsychotics, any hormone therapy, or any anti-seizure meds. Whether the patient is consuming any psychotic substances or is addicted to alcohol or smoking must be taken into consideration. The review of previous surgeries, any abdominal or bariatric surgery, and risk assessment for DVT is important. So physically, while we assess the patient for BMI, the cardiopulmonary status, and also abdominal examination to assess for the above. Then coming to the laboratory investigations, the routine investigations like complete blood count, the coagulation profile, the liver function tests, the renal function test, the lipid profile, hormone status, including the cortisol, insulin, looking for any vitamin deficiencies which may happen in these patients, iron profile, the HbA1c status, the fasting and the postprandial blood sugar levels, and also the viral markers. As far as the imaging is concerned, the patient may be subject to an ultrasonogram with the abdomen and pelvis and the Doppler study, provided there is any antecedent risk factor for DVT in these patients. So coming to the broad topics of a cardiovascular assessment, we routinely perform ECG, electrocardiogram, or echocardiogram may be done to know about the cardiovascular status of the patient or any arrhythmias or any congestive failure. Then we may if there is any problem, we may subject the patient to a stress testing by a myocardial perfusion imaging or a dobutamine stress test. And we must look for the risks of the venous thromboembolism in this patient, because we must note that post 30 days, the most common cause of mortality after a bariatric surgery is venous thromboembolism. Coming to the pulmonary evaluation, the patient must be screened for sleep apnea. The most commonly used questionnaire is the stop bench questionnaire, which takes into consideration about the snoring, the tiredness, the observed apnea of the patient, high blood pressure, increased BMI, a neck circumference of more than 40, and male gender. So if these things are suggestive of sleep apnea, the patient may be subject to a polysomnography or a home-based sleep study to be performed. Pulmonary function tests must be done for the patient who give history of COPD or any other pulmonary disease. We must note the saturation of the patient, which may help indicate both as well as during sleep and the awakened period for any pulmonary disorders like the obesity. Sorry, there was a disconnection, sir. Sir, am I audible, sir? Hello?
Connection in between.
Hello, sir?
Yes, we can hear you. Yes.
You are quite audible, please. Go on.
Thank you, sir. Sir, as I was discussing the pulmonary evaluation, the obesity hypoventilation syndrome, in which we may find that the patient is obese and we can assess that there is an increase in the PCO2 level of more than 45 mm of mercury. And the patient does not have any other neurological factors which may aid to this retention of CO2. So the gastrointestinal evaluation part, in which we can do an upper GI endoscopy to evaluate for hiatal hernia, the GERD, or any gastric ulcers, and also simultaneously look for any H. pylori infection, becomes important in certain patients who have a prior history of reflux or retrosternal burning sensation, because this may further cause increase the risk of any marginal ulcers or any other associated pathology like a Barrett's esophagus or severe GRD may influence the choice of a surgery. So there is a debatable role of a routine upper GI endoscopy before a bariatric surgery. We have noted that in patients with a BMI of 25 to 30, there is a 1.43-fold greater odds ratio risk of esophagitis and 1.94 times greater risk for esophageal adenocarcinoma. And as the BMI increases to more than 30, the risk factor also increases to 1.94 for esophagitis and 2.78% for esophageal adenocarcinoma. So there is a mixed data regarding the safety of performing a laparoscopic sleeve gastrectomy in patients with severe GRD or esophagitis, as this procedure has been shown to both exacerbate the pre-existing reflux disorder and even generate a de novo possibility, placing such patients at higher risk for Barrett's. So then we come to the endocrine and the metabolic evaluation. Diabetes management is of prime importance because we have to optimize the blood glucose level of the patient prior to surgery. A poorly controlled diabetes can increase the risk of infections and poor wound healing. So adjustments to medications, the insulin intake must be done in consultation with the endocrinologist. We have to assess for the thyroid function. The TS is the free T4 and free T3 in patients with known or suspected thyroid dysfunction. For patients with metabolic syndrome, having high blood glucose level, high blood pressure, high lipid profile, increased waist size, and low HDL levels, proper screening must be done in this regard. And also, we must look for any vitamin and mineral deficiencies in the patient, namely the vitamin B12, the folic acid, the ADEK. And proper supplementation has to be done in the preoperative management of the patient prior to surgery. One thing that is commonly not taken into consideration is the psychological and the psychiatric evaluation. So a patient who has got a mental health condition like a depression, anxiety, or a eating disorder like binge eating, night eating syndrome. So we must take a detailed history for the patient, whether the patient is a grazer, that is, he or she goes on eating throughout the day, whether it's a night eater, or it's a binge eater, or there is voluntary overeating, there is stress overeating, or there is increased intake of dietary fat. All these must be taken into consideration. The lifestyle pattern of the patient, whether the patient follows a strictly sedentary lifestyle or it's an active lifestyle, but despite of that, the patient is having an increase in the body weight. Then the patient must have a proper support system where we assess the patient support network, and a strong emotional and social support has to be provided to the patient both before and after the surgery. And we must explain the patient about realistic expectations, as in the surgery does not give the patient a reduction in the body weight overnight, and that it is a long duration process in which gradually the patient, if he or she follows strict norms, there will be ultimately help in the reduction of the body weight and subsequent comorbidities. As already mentioned, the nutritional evaluation has to be done, and we can do that screening by a registered dietitian who shall provide a battery of tests regarding the current vitamin and nutritional status. And also, we must take into consideration whether the patient is a vegetarian or a non-vegetarian patient, and then the priority goals has to be achieved. So this also helps to know about the mental makeup of the patient, whether he or she is ready to take up dietary modifications further. And so we have to tell the patient prior to surgery that these are the nutritional criteria that you are following at this present point of time, and these are the criteria that you need to follow later on. Sometimes we may see on an USG abdomen that the left lobe of the liver of the patient is large. So in that case, we may subject the patient to a liver shrinkage diet, which is a diet low in fat, sugar, and carbohydrate. And the diet helps in the reduction in the size of the liver by reducing the glycogen stores. So these diet provide around 80 to 1000 kilocalorie of energy to the patient with less than 100 gram of carbohydrate. Then it should be low in fat, high protein, and the patient should consume a minimum of around 2 liters of fluid. So in a patient with a BMI of less than 50 kg per meter square, around 2 weeks of duration is seen to be enough, whereas a patient with a greater BMI, the patient may need even 4 to 12 weeks of a liver shrinkage diet to come to a proper size of the left lobe of liver. We must talk to the patient, counsel the patient, and see whether the patient is on board with us, and he or she is ready to follow the practices which have been advised to the patient. Just for example, the 20-20-20 rule, in which the patient is asked to chew the food 20 times and take 20 seconds to swallow and wait for 20 minutes between meals or snacking. Maintain a proper hydration status, consumption of protein-rich food and nutrition supplements, and also that the patient avoids doing certain things in his day-to-day habits, like consumption of liquids 30 minutes before and after meals, consumption of sugars, and also alcohol consumption, caffeinated drinks, and smoking.
हाँ नहीं नहीं, वो तो वो है बेरियाट्रिक प्री ऑप इवैल्यूएशन पे ले रहा है डॉक्टर नरवाड़िया मॉडरेटर.
Multidisciplinary team involvement. This entire bariatric surgical procedure is not done by just by the surgeon. It has to be taken into consideration by the entire multidisciplinary team, starting from the dietitian, the psychologist, the psychiatrist, the anesthesiologist, and the specialist physicians who assess the metabolic endocrine functions, the cardiopulmonary functions, and the GI evaluation. So everyone has to be on board along with the patient. Preoperative weight loss. Any attempted weight loss prior to surgery gives an idea about the insight of the patient and the willingness of the patient to further continue doing so post-surgery. So losing weight before surgery, one can reduce the size of the liver, as mentioned, making laparoscopic surgery easier, and also helps improve the overall health of the person. And the short-term goal of losing 5 to 10% of the body weight is often recommended. This table enlists the medications which are usually advised to the patient in the form of a orlistat, a locasarin, or a liraglutide. Then we come to the special populations. One is the pregnant female or a patient who is planning for pregnancy. So pregnancy may be easier to attain following bariatric surgery, as it helps alleviate infertility at times with weight loss. But however, post-bariatric surgery, the patient may face some risk during pregnancy, like protein vitamin deficiency, malabsorption of nutrients. So ideally, a pregnancy should be deferred by around 18 to 24 months. In case of a transplant candidates, the bariatric surgery may act as a bridge to transplant for in patients as in end-stage liver disease. And also, it has been seen that laparoscopic sleeve gastrectomy and gastric bypass have shown promising results in acting as adjunct to treatment in patients with obesity and heart failure before a heart transplant or a placement of an LVAD. The laparoscopic sleeve gastrectomy appears to be a safe and effective modality and less technically demanding in patients undergoing a renal transplant. As far as the adolescents and elderly are concerned, it is not a contraindication, and bariatric surgeries are now being conducted both for younger age group patients, as endorsed by the American Academy of Pediatricians and the ASMBS, in which a BMI of more than 120% of the 95th percentile, that is a class 2 obesity with a major comorbidity, or more than 140% of a 95th percentile, that is a class 3 obesity, are candidates for undergoing a bariatric surgery even in adolescent populations. These are carefully selected obese adolescents who have other comorbidities like uncontrolled diabetes mellitus, and have been thoroughly screened and are fit for surgery and then taken into consideration. Primarily, the Roux-en-Y gastric bypass is performed, or a sleeve gastrectomy may also be done. And as far as the elderly is concerned, there is no upper age limit to a bariatric surgery, but frailty, cognitive capacity, the smoking status, the end organ function acts as better predictors rather than just age alone in these patients. So special considerations, the anesthetic risk involved must be, the anesthetist must be aware that these are not other patients in which the intubation is relatively easier. They may face with difficult intubation, ventilation, and increased risk of aspiration. And also the patient has to be aware that there may be risks of infections or wound healing, wound dehiscence, which may occur later on with uncontrolled diabetes or any chronic conditions which may lead to hampering in the immediate recovery of the patient. So prior to undertaking surgery, we have a risk stratification model by the name of the obesity surgery mortality risk score, which helps to assess the risk of mortality in the patients undergoing bariatric surgery. This score entails the age, the body mass, the BMI of more than 50, the male gender, patients with hypertension, and risk factors for pulmonary embolism. So each factor has been given a score of 1, and then we calculate based on the score of the patient as a low risk, intermediate risk, or a high risk of the patient. There are other risk calculators available like the MBSA, QIP, bariatric surgical risk and benefit calculator. Coming to the fag end of the discussion, we have the preoperative checklist, wherein the proper documentation of the consent forms and the insurance approvals have to be done, and the patient is made aware of the final reports and the evaluations. The patient's readiness is and understanding has to be taken into consideration, and then a multidisciplinary team approval and final clearances for surgery is to be taken. So I would like to conclude by saying that the comprehensive preoperative evaluation becomes critical for identifying and managing the potential risks, optimizing the outcomes, and preparing the patients for life after surgery. A multidisciplinary approach ensures that all aspects of the patient's health are addressed to maximize the success. Patient education and psychological readiness is of pivotal importance in achieving a long-term weight loss and improving overall health. These already laid guidelines help in reducing the stigma associated with obesity. When the people recognize obesity as a medical condition, they are more understanding and supportive, fostering through a preoperative evaluation, and is thus essential for safety and success. Thank you.
Thank you, Gaurav. Thank you. It was a nice presentation. Few comments and for discussion.
Yes, sir.
Yeah. So one was about this Utah and Stampede trial. Utah trial was done on a larger population wherein they have taken the driving license, people from the driving license, and then they followed. In US, everything is on database. So they evaluated the patient with their weight at that time, and then they followed them for the long term, and then they found that mortality rate is more in those who are not getting bariatric surgery and those who were obese. Similarly, the Stampede trial was having 50 surgeries of Roux-en-Y, 50 surgery of sleeve gastrectomy, and 50% in medical management, intensive medical management. And then they were comparing, and where the outcome of Roux-en-Y was better than sleeve gastrectomy, and definitely the intensive medical therapy with surgery are better candidates, and they were good at the long term. Then another topic is diabetic patient. You need to know the pancreatic function, pancreatic reserve. See, because of the duration of diabetes, sometimes the pancreas get burned out. So you need to do the C-peptide, HOMA-IR, islet cell antibodies, and those tests are specifically required for those who are having bad diabetics. And we have a diabetes scoring system also. So we can assess the diabetes, and then we can always tell this person will respond to our metabolic surgery, and this will not respond. So you can clear-cutly say this person, yes, you will not. You will be getting this much result with this surgery. See, improvement is there in every person because of weight loss, but whether their pancreas function will improve or not, that all depends on their pancreatic reserve.
Yes, sir.
Then another topic was DVT evaluation.
Yes, sir.
Those who are bedridden patient, in them we need to have Doppler study, or if they are not mobile, we can have MR venogram. Because even sometimes the pelvic veins are having thrombosis. So these patients are to be placed before surgery on prophylaxis, and they continue for at least 3 weeks post surgery to avoid future DVT complications or embolism.
Okay, sir.
And H. pylori is common in every patient, so H. pylori is not a contraindication. See, upper GI endoscopy is still not compulsory to do in every patient, but yes, if it is done, it is always better. But H. pylori is not a contraindication for bariatric surgery. But once we diagnose H. pylori, we can always treat it in a postoperative period because we know. So what I do during surgery, we always take a biopsy from the stomach and we do H. pylori on table. And these patients, we always place this slide on the file, and on subsequent follow-up, we always put them on H. pylori course. So far, I have done more than 200 such patients, and everybody is H. pylori positive. That means if we stop doing this surgery and avoiding treating H. pylori for 2 weeks and then doing this surgery, it will delay the procedure. But we can always treat them after surgery also. Then liver size. Every patient will not be placed on liver diet or liquid diet before 50 BMI because you are delaying the procedure. What is important is that during sonography, you can always see the stomach. Whether your liver is completely overlapping the stomach, then it is difficult to do surgery. These patients are to be placed on liquid diet or size reduction therapy before surgery. That includes liquid diet. We can use the newer GLP-1 analogs and something for 2 weeks to reduce their weight. Also, we can use CPAP because these patients are having sleep apnea. So we can use CPAP or BiPAP so that water retention get reduced, their mobility get improved there, and they can be taken safely for the surgery.
Okay, sir.
Then age less than 18 and more than 65 is not contraindication, but these patients are to be taken by a multidisciplinary team and only by a high volume centers. Somebody getting a first patient as a pediatric patient should not be offered this surgery. So that is one. So safety is more important in this patient. And older age, the weight loss is not important. The quality of life is important. So weight loss, 100% extra weight loss is not desired. It is only say 15 to 20% weight loss will improve their quality of life. Are definitely desirable instead of having a more weight loss. So we need to tailor the surgery so that we don't reduce their food capacity so much. Only hormonal changes will only reduce their weight because every surgery has increased GLP-1 production. Their appetite goes down and they can lose weight. So we don't reduce the capacity so much in this age group. And my oldest patient was 83 years, who is now 93. So it is more than 10 years, who was bedridden before surgery. Now he's mobile and ambulatory. So that is the outcome which we are looking at. LSG in younger patient, that is what you say. It is actually other way because we need a procedure for younger patient which is lasting longer. So as you know, LSG, the weight regain is much faster. 40% people will gain weight after LSG after 4 to 5 years, and 30% patient will have reflux. So we don't want to offer something which is not long lasting. So younger patient, we need a surgery which is lasting longer so that they can maintain their lifestyle over a period of time and they can maintain their weight with the procedure. So we have a different modification of LSG. Now we call it sleeve plus procedures, which can be added with sleeve and to decompress the stomach and they don't regain weight, or we can reduce the reflux complications. Okay.
Yes, sir.
Kapoor sir has joined. Let us
Anand, you want to
his
add?
comments.
Rajen, you want to say something? You want to add something? Are
I
you
have
still there?
absolutely no idea about this condition,
Okay.
so I don't want to say anything. I think Mahendra has covered it in great detail, and Gaurav has covered it in great detail and beautiful presentation.
Thank you, sir.
So I have a couple of questions. Maybe Gaurav can take them as a student and then Mahendra can. So DVT prophylaxis, Gaurav, in malignancy, it is recommended that you do an extended prophylaxis. Some reports say even up to 3 to 6 months. What is the optimum or recommended duration of DVT prophylaxis? Dr. Mahendra did mention something, but what have you studied?
Sir, as far as I am aware, sir, unless there is a documented sir DVT, just as we are talking about the prophylaxis part, so usually the patient is not subjected to such a long duration. If the patient is at risk or debilitated, we do a Doppler study, and if it doesn't come out to be any DVT, just prior to a bariatric surgery, we give the patient a 0.6 ml subcut dose of a Clexane probably, and the patient is subjected to surgery. And then following that, till the patient is in hospital stay, we continue giving injectable forms, and then we shall later on discharge the patient if provided so there is no known DVT in the patient.
Wrong answer. I asked you about prophylaxis. I never talked about treatment. So there's no question of Doppler. Doppler is for diagnosing. Prophylaxis is that you are giving it to prevent. So again, answer again. How all these patients are at risk? I think all patients who are undergoing bariatric surgery would receive DVT prophylaxis, isn't it?
Yes.
Yes, sir.
Now the question is, how long do you give the prophylaxis after the patient has been discharged? Patients are usually discharged on day 2, day 3, maximum within a week, isn't it? After laparoscopic procedures. But
Yes.
how long do you recommend the prophylaxis? That was the question. If you don't know, say, I don't know.
Sir, I'm not totally sure, sir.
Mahendra?
Yes, sir. It is 3 weeks for those who are high-risk patients. That is what recommended. And those who are low-risk patients, you can discharge them if they are ambulatory, having good hydration, and they are not at risk of, or somebody like pre-existing DVT in the past, you can always keep them on longer period of time. Maybe oral medicine, you can give even 3 to 6 months till they loses some weight, and we always check these patients whether their previous veins are recanalized or not.
So the answer is that it depends on the risk, degree of risk. Low risk patients, only while they are in the hospital. Once they are ambulatory, you can stop it. If they are high risk, and there are, the factors for high risk, one of which is previous history of DVT, because these patients may have had a DVT in the past, then you give extended prophylaxis, which, as Dr. Mahendra said, is 3 weeks. Okay. Next question is H. pylori. Now, Dr. Mahendra did mention something about intraoperative, but is it recommended that, as you said, that you do an upper GI endoscopy, do H. pylori and eradicate it? Is that the standard practice? Because more so in our population where prevalence is so high, H. pylori infection prevalence. What is the recommended practice?
No, sir, it is not recommended that we do it for every patient as such. But say, for example, sir, if we are doing an upper GI and then we find, sir, an ulceration in that, so in that point of time, sir, a biopsy may be taken. But eradication, as sir, you have already mentioned that in our clinical setup, the patients which we deal, sir, most of the patients turn out to be, sir, H. pylori positive. So it does not necessitate that we first eradicate or give the patient and delay the process. So if we feel that it is a positive, either we can take a small biopsy and do a RUT, or later on post-discharge subject the patient to eradication program. But we need not delay the procedure and eradicate prior to surgery.
No. In any case, these patients are waiting between the evaluation and surgery. There is a gap because you said so many things have to be done. So do you look for H. pylori and eradicate it while you are working up the patient?
No, sir, not routinely, sir.
Mahen, what is the practice?
Sir, we don't have waiting. Whenever they comes, we operate the same day if they are evaluated in a shortest possible period of time. So there is no waiting for such person. Only those who are waiting for some preoperative weight loss, or you have a busy list, then yes, you can do endoscopy and you can eradicate before surgery. Like America, I think they have waiting list for more than 6 months. So they can always do it. But in India, I don't think we need to eradicate before surgery.
So it is not required.
It's not required.
Okay. The third question is, you said that in very high BMI patients or very high risk patients, you try to reduce the liver volume by this liver shrinkage diet and maybe some weight reducing drugs. Now, suppose the patient doesn't respond to this. Is it a contraindication for surgery? Does it indicate that patient would not respond even to bariatric surgery procedure? So is it like a therapeutic trial?
No, sir, I think everybody has to respond. I'll just give you an example. Last month, I had a patient who was admitted in emergency, and they said, you do an emergency bariatric surgery. When she was admitted, her saturation level was 70%. Room air saturation was 70%. When we did sonography, liver was reaching up to right iliac fossa, and the sonologist was not able to see any organ below the liver. And the abdomen was stony hard. You can't even press. There is not even pitting. It was too hard and PD orange appearance of the skin. And we put this patient on liquid diet, Monjaro injectable, and BiPAP diuretic in infusion. And we reduced 25 kg weight within 3 weeks because of the edema itself. So then the liver has shrunken. We did another repeated sonography to this patient, and we found that liver has gone to near normal, and then we did surgery and we could discharge her. And when we discharged, she was on room air more than 90%. So these kind of patients we get, and we always prepare them. And I've not seen a single patient where we could not reduce the liver size.
Any of the students would like to ask anything? You can unmute yourself and ask. Make use of the opportunity of presence of Dr. Mahendra Narvaria, one of the leading bariatric surgeons of the country. You can ask him beyond the topic also, because we have time. So if anybody wants to ask anything related to technique.
In fact, to say, I had a patient at least 3 occasions wherein we tried to place a port at a Palmer's point, and liver was too big. I could not get, intra-abdominal pressure was too high that we could not place other ports. And I had to come out. I said, we cannot do the surgery and we have to prepare. And these patients came from different part of the country, or fewer foreigners. I said, you have to stay here in India for more than a month now, just to prepare yourself. And then we put that patient on liquid diet, diuretic, and anti-obesity medications, reduce her weight, and then we did surgery. So at least at 3 occasions, I had to come out intraoperatively without performing the surgery.
Coming back to the question of the age, the adolescents and young adults. Yes, Jiten, Dr. Jiten, yes, please ask.
Yes, sir. Sorry, sir, to disturb, sir. Please, sir, I have just a question to the sir. Sir, during the LSG, what, sir, do you plan, sir, with the bistaple line or tristaple line? What stapler do you use to do the laparoscopic sleeve gastrectomy, sir?
Tristaple. It is always. See, tristaple is a new technology. It is always, otherwise the staples are always in 3 line. So we don't have the 2-line staplers available in the worldwide. It is always 3 lines.
And sir, do you overrun the staple line with the suture after doing the surgery to prevent the corner stitch leak, which might be the case in case of laparoscopic sleeve gastrectomy?
In fact, I had leak only when I was over suturing it, overrunning the staple line, and once I stopped it, I never had leak. So I believe the staplers are better than over suturing. When suturing is only for hemostasis, not for the leak. So you cannot stop leak by overrunning or suturing the staple line.
Mahendra, there are 2 questions in the chat. There is a question that whether the patient is vegetarian or non-vegetarian, does it affect your choice of the procedure?
Yeah, I think the OAGB is having a maximum weight loss, and these patients, if they are non-vegetarian, it is preferred because the protein intake is better achieved. In fact, this few patients who are pure non-vegetarian, like eating day and night or every meal they have non-veg, I prefer to do OAGB in them rather than sleeve gastrectomy or Roux-en-Y. So, and I don't do sleeve at all in my practice except the pediatric age group, because anybody who's more than 15 years of age, I always do a sleeve plus, wherein we join the, if you can make me host, I can show you the new procedure which I have developed. Gaurav, can you just stop the presentation and allow me to share the screen?
Yeah, just, yeah, Gaurav, can you stop sharing? Mahendra, 2 more questions. That does the length of alimentary limb and biliopancreatic limb, does it vary depending on veg or non-veg?
No. Actually, in India, we don't go beyond 200 centimeter of intestine by combination biliopancreatic limb or alimentary limb. We should not go beyond it in a primary surgery. So even if we do OAGB, the highest limb which we are using is only 150 centimeter, and we can achieve a good result with that. So we are not going beyond jejunum. So the total length is not required to be measured. Only when you are doing revision surgery and adding more malabsorption, yes, we have to have at least 40% of common channel which is available for absorption.
Students should understand that according to religious definition, if you take meat even once in your life, you are a non-vegetarian. But according to medical definition, non-veg means that you take meat or a non-veg product, if I remember correctly, at least 5 times a week or something. So by that definition, most of us are probably not true non-vegetarian according to medical definition. There's one more question. Dr. Badri Narayan Sharma, what other procedures are used in LSG plus? What do we mean by LSG plus?
So LSG plus, they have multiple processes. I'll just show you
Yes.
some
Yeah,
slides.
now you can share. You are a host. You can share. So while Dr. Mahendra is sharing, I need to inform the students and everybody who's attending that Dr. Mahendra is one of the pioneer bariatric surgeons of the country, and he has performed all procedures in bariatric surgery, starting from band to the most complex ones.
Sir, stop share and share again, sir.
I think I'll get it.
हाँ, एक बार stop करके फिर दोबारा share करो.
So sleeve plus is a surgery wherein we can add anything after sleeve. So if we do duodenal switch, that is also sleeve plus, because we are connecting a ileum there. In duodenal switch, there is always a ileum which is connected there. This is sleeve plus, wherein we are joining a loop of intestine like jejunum, gastrojejunostom, which is done. That will decompress the sleeve. Can you see the screen? Hello?
Just click escape once.
Escape once. Now?
No, sir. We are not say any video.
No, just a minute. I'll again share it. Now?
Yes, sir.
Yes.
Now we can see.
Yeah. So the problem with sleeve gastrectomy is that whenever we do sleeve, it is a high pressure system in between two valves. So over a period of time, because of this high pressure system, sleeve will get dilated. So over 4 to 5 years, it will get dilated. So this person will get will have weight regain. And in this process, sometimes the G junction also get dilated, and you have a esophagus and stomach as a single unit, and they have more reflux. So 30% people will have reflux and 40% people will have weight regain. So you need almost 70% person who may require revision surgery after sleeve. So what I have done is in last almost more than 12 years, I stopped doing sleeve. I do always something which is beyond sleeve. So what we do is just to reduce the stomach pressure, we can join a loop like this. And this processor will behave like MGB or OAGB only, because since the anastomosis is 6 centimeter, most of food will be going only through this route. And initially in first few months, it will go partly through this, but eventually it will behave like MGB. The only advantage here is that we have access to the stomach antrum and we have access to duodenum. So in future ERCPs or CBD access is possible with this surgery, and it is more commonly used in patients who are having portal hypertension, gastropathy, or even cirrhosis. This is a procedure of choice. I personally feel that since it behaves like OAGB, means there is more malabsorption. So I prefer to do a Roux-en-Y. This is what I have developed the procedure, where we join a Roux limb here, connecting here. So here the quality of life is very good. In a previous surgery, there is a theoretical possibility of bile getting exposed to antrum, and they have aversion to food and sometimes even bile gastritis. So to avoid it, it is preferred to have a Roux limb attached with the sleeve, and we have jejunostomy here. Here, this BP limb length is variable depending on the weight loss requirement, diabetes, presence of diabetes, and duration of diabetes. So it depending upon 75 centimeter to 100 centimeter BP limb and 75 to 100 centimeter of row limb. That is what we design according to the needs. So it is a tailored procedure for every patient. Then,
But in these procedures, Mahendra, the sleeve is same as the classical sleeve.
no, we can have little loose sleeve when we are getting people or patient coming only for diabetes, wherein we don't want much weight loss. Like the weight loss requirement only say 10 kg or 15 kg. Then we can have a loose sleeve, but yes, fundus has to be removed just to have a ghrelin effect. So we need to reduce the ghrelin in this patient. And we have similar procedure like gastric plication and joining a root limb here. And this is our article on liver cirrhosis, review article. So we get such patients also coming to us. So there is a PJB also wherein they put we disconnect the jejunum and leaving about 200 centimeter of jejunum blind and then joining the ileum, jejunum with the ileum. So that is called PJB. It was practiced by our Taiwanese group, Dr. Wang, who is doing it. So PJB, sleeve bipartisan, and that different names given to these sleeve plus procedures. So we can have a complete topic only on sleeve plus. We have a presentation on that, which will take at least an hour to cover.
So I think we will plan another session on the surgical procedure.
Yeah.
Anand will ask one of the students to prepare a presentation on surgical procedures, various surgical procedures, indications and contraindications and problems. Gaurav, you want to ask anything from Dr. Mahendra?
No, sir. It was a nice interaction with sir. Got to know a lot of things. Thank you so much, sir.
So, Mahendra, do you think that whatever Gaurav has presented, was it good enough to be converted into a review article, which he can, if he wants, he can write and then you can edit it and then we can submit it to some journal as a review?
Yes, sir. I think he has done good work and good research also. I think it was a nice presentation.
Gaurav, yeah.
As
Gaurav,
a resident, I have not
if-
seen any resident doing so well. So
Yeah.
I congratulate him for doing a fantastic presentation.
Thank you so much.
Gaurav, if you want, you can try to convert this into a review, add some recent references of some good guidelines, and then Dr. Mahendra can go through the scientific content and edit it. And then we can submit it to some Indian journal of either minimal invasive surgery or bariatric surgery. It will be a good opportunity. Since you put in so much of effort, just put in a little more extra effort and you will have a good publication.
Sure, definitely, sir. Thank you. Yes, sir. Sure.
Okay.
Thank
Okay.
you so much.
Thank you.
So-
Thank you so much, sir. Thank you.
Thank you, Mahen. Thank you very much for joining. Thank you very much. Okay, we will close the session.